Hi, I'm Dr. Jessica Langenhan, a practicing psychiatrist, and today we're going to discuss 3 myths of treating depression. Now, this video is for anyone, for depressed patients, for their loved ones, and for doctors. If you are a doctor, check out my course at MedMastery for additional information. So the tips I'm going to discuss today are going to help you, your loved ones, or your patients get on the road to recovery. Myth number 1, there's always a cause for depression. So sometimes this is the case. Depression can be caused by a sad event like the death of a loved one, or from stressors like losing a job or dealing with a difficult boss. Sometimes there's childhood trauma that plays a role, and sometimes we have a family history of depression. But other times there's no reason at all for a depression. However, just because we don't know the reason doesn't mean we can take it any less seriously. Also, unlike what some people, including some doctors, might say, you can't just snap out of it. We do have specific treatments for depression, which I'll discuss later in the video. We may not always know how you got here with depression, but we do know how to help you to feel better. Myth number 2, depression always looks the same. So depression can include things like sad mood, feeling empty, having less pleasure in things, feeling hopeless, worthless, or having feelings of guilt. There may be changes in appetite and weight, and there might be sleep and concentration difficulties. But not everyone has all of these symptoms all the time. Some sleep too much, some sleep too little. Some feel restless. Some people have an increased appetite, while other people have a decreased appetite. Depression can also look different in different populations. For example, adolescents may seem more irritable than sad when they're depressed. In adolescence, we also look for different warning signs, such as avoiding friends or changes in their school performance. So always consider your patient's background when looking for signs of depression. In terms of how to recognize depression, we do have scales such as the PHQ-9, which can help to screen. But it's really important for doctors to have these conversations with their patients about depression. It's important also to recognize that some patients may have difficulty recognizing or wanting to discuss these symptoms with their doctors. Myth number 3, treatment for depression is a one-size-fits-all. There's no one medication, such as Prozac, that works for everyone. Patients may need to try a few different medications before they find the one that works for them. We also want to consider certain side effects that specific patients may need to avoid. For example, patients with sensitive stomachs may need to avoid medications that can cause a lot of nausea. We also need to consider what specific effects from certain medications can help particular patients. For example, a patient with low energy or poor concentration might do well with bupropion or an SNRI. If a patient is having significant anxiety, however, bupropion may not be the best option. Mirtazapine is a medication that we use a lot for insomnia or for decreased appetite or feeling restless. For patients with comorbid pain conditions, duloxetine can be used for chronic pain. If someone's on multiple medications, escitalopram is a possible option because it tends to have fewer interactions with other medications. Of course, medication is just one approach to treating depression. There are also many different kinds of therapy, like client-centered, psychodynamic, and cognitive behavioral therapy, or CBT, that can be considered. Again, check out the course to learn more about those. Client-centered therapy, or what we think of more as supportive therapy, is when the therapist provides validation and support for the patient without providing a lot of specific guidance. Patients who feel that they may need a vent or have like a sounding board are usually best suited for this type of therapy. CBT is the type of therapy that looks at our thoughts, emotions, and behaviors and how they are all connected. It usually involves homework and is very structured and time-limited. Patients who like structure and like having things to work on outside of the therapy session are often best suited for CBT. Psychodynamic therapy looks at patterns that we see in relationships and past experiences and how they're affecting a patient's current decisions and behaviors. Patients who feel that a lot of their problems might be stemming from relationship and friendship issues would be a great fit for psychodynamic therapy. There are so many different types of therapy out there, so it's important to consider the individual's specific needs and goals. So for doctors, just remember, there are many different tools out there to help you treat depression in your patients. And if you're depressed or care about someone who's depressed, there are many different resources to try as well. So I'm confident that you'll be able to find the ones that will work best for you and get you on the path to feeling better.